maybe start. Mike, are we good to go?
Yes, Doctora. This is
All
Marby.
right.
We're ready.
Okay. All right. So good evening, everyone. My name is Judith Gapasin, and I'm your moderator for the very first Philippine Society of Digestive Endoscopy, ERC, for the fiscal year 2020-2021. We start off tonight's activity with an invocation followed by the national anthem.
Let us pray. Lord Jesus, as we enter this training hall, we bring your presence with us. We speak your peace, your grace, and your perfect order into the atmosphere of the session room. We acknowledge your lordship over all that will be spoken, thought, decided, and accomplished within these walls. Lord Jesus, we thank you for the gifts you have given to each one of us. We do not take them lightly, but commit in using them responsibly and well. Give us a fresh supply of truth and beauty to which we draw our strength in doing our job. Anoint our creativity, our ideas, and our energy so that even our smallest tasks may bring you honor. Lord, when we're confused, guide us. When we're weary, energize us. Lord, when we're burnt out, infuse us with the light of your Holy Spirit. May the work that we do and the way that we do bring hope, life, and courage to all that we come into contact with. And Lord, even in these days, most stressful moments, may we rest in you. In your strong and powerful name we pray. Amen.
To those who have just joined us, welcome to the first endoscopic radiologic conference for this fiscal year. This is hosted by St. Luke's Medical Center, Quezon City, and the University of the East Ramon Magsaysay Memorial Medical Center. So to give the first of two opening remarks this evening, I'd like to call on the chairman of the Institute of Digestive and Liver Diseases of St. Luke's Medical Center, Quezon City, Dr. John Arnel Pangilinan.
Hello, Jet.
Hi.
Can you hear me?
Yes, Doc, I can hear you.
Okay.
Okay.
Thank you, Jet. Looking good as always. Huh?
Thank you so much.
Okay. Good evening, everyone. I hope you're staying safe and healthy. And we know that we're making a lot of adjustments during this pandemic. No? But I think a silver lining would be we're not braving any traffic. No? And I think we will have a very good attendance, no, for this conference. First, I would like to congratulate the newly elected officers of the Philippine Society of Digestive Endoscopy, no, and proof of their hard work is continuous learning activities, no, despite our situation. And tonight's conference is the very first one for the year, no. And I hope their efforts are not wasted and that we will learn a lot from tonight's conference. So once again, welcome and have a great meeting tonight. Thank you.
Thank you, Dr. Pangilinan. Now, to give the second opening remark, we have the chairman of the GIT and Liver Study Unit of the University of the East Ramon Magsaysay Memorial Medical Center, Dr. Luis Abola. Dr. Abola, go ahead.
Hello, good evening to everyone. Good evening to John and to Jet.
Hello.
Again, I'd like to also congratulate the new members of the board of PSD, and I'd like also to welcome the new fellows. I think this is the first activity of our first-year fellows for the year. Hopefully, you will be able to follow the ERCs. The ERCs are intended to introduce you to endoscopy and also to correlate it with radiologic and pathologic findings as needed. Again, the PSD is trying to adjust to the new reality, that we have to do all of these things to telehealth. And I agree with John. We don't have to brave traffic. We get to, there's no excuse anymore for being absent. Okay. Disadvantage though is that you miss the opportunity to meet each other for the fellows, because I know that after each activity, there's a post-activity fellowship for the fellows that they get to meet each other. So hopefully, after several months, you'll be able to see each other so that, you'll be batchmates, and hopefully you'll be able to help each other as you go in your training as well as when you go into your practice. So good evening and congratulations to both institutions for their presentations tonight.
Thank you, Dr. Abola. So at this juncture, I would like to acknowledge the officers of the Philippine Society of Digestive Endoscopy. They're namely the following: Dr. Marie Michelle Escloa, our president; Dr. Benjamin Gerardo Perez, our vice president; Dr. Julius Cosoriano, our corporate secretary; Dr. Carl Yukim-Teng, our treasurer; Dr. Patricia Ann Prodigalidad, our PRO; and the board of directors, namely Joseph Carlo Lazaro, Ruther Maralit, Ronald V. Romero, and Jerby Coronel. So welcome, dear officers and board of directors of PSDE. Now, I would like to introduce our esteemed reactors for this evening's ERC. So our first reactor is a graduate of medicine from the Far Eastern University and had his residency in internal medicine at the University of the Philippines, PGH, Philippine General Hospital. He likewise had his gastroenterology fellowship in the same institution. He underwent post-fellowship training in therapeutic endoscopy at the Prince of Wales Hospital in Hong Kong under Professor Joseph Leung. He has served as training officer in the following institutions: at the Department of Medicine of the National Kidney Institute and at the Manila Doctors Hospital. He likewise served as the training officer at the section of gastroenterology at the UPPGH and at the Manila Doctors Hospital. He is currently an active consultant at the section of gastroenterology at the Manila Doctors Hospital. He is none other than Dr. Virgilio Banyas. Hello, Dr. Banyas, welcome. Our second reactor is a graduate of the University of the Philippines in Manila who had his residency in internal medicine and likewise his gastro fellowship at the UPPGH. He underwent further training in interventional endoscopy at the National University Hospital in Singapore. He is currently a clinical associate professor at the Division of Gastroenterology at the UPPGH. He is an assistant training officer at the University of the Philippines, PGH likewise, Division of Gastroenterology, and at the Department of Medicine at the Medical City. He is currently a board of director of the Philippine Society of Digestive Endoscopy. He is none other than Dr. Ruter Maralit. Hi, Ruter, welcome. And lastly, we have invited a resource person, a radiologist who is an active consultant at the Institute of Radiology at the St. Luke's Medical Center in Quezon City. She is a member of the clinical faculty of the St. Luke's Medical Center College of Medicine, a consultant at the MRI section of radiology of both VRT Medical Center in Mandaluyong and Diliman Doctors Hospital in Quezon City. She's a member of the Residency Training Committee in Radiology and a member of the Fellowship Training Committee in CT, MRI, and Ultrasound at St. Luke's Medical Center in Quezon City. She's none other than Dr. Ana Maria Saulog. Hello, Dr. Ana. Welcome. So before we proceed with our cases for this evening, I would like to go through some housekeeping rules. You will notice that all participants have their microphones muted and their videos off. As for the reactors, they're the only ones who are allowed to ask questions verbally, and the reactors need to click on the raise your hand button in the Zoom app. As for the others, if you have any questions, you may type them in the chat box located on your screen, and we will try to accommodate as much as we can in the time allotted to us. Just a reminder, the purpose of the ERC is to highlight the correlation between endoscopy and radiology. So therefore, the entire case may not be presented to us just like in a regular case conference. So with that, we'd like to present our first case from St. Luke's Medical Center in Quezon City. We have a second-year GI fellow, Dr. Kimberly Lim Fernandez. So Kim, you may go ahead and share your slides with us.
Okay, so good evening, doctors. Good evening, co-fellows. I'm Dr. Ann Kimberly Lim Fernandez, a second-year GI fellow representing St. Luke's Medical Center, Quezon City. Once again, welcome to our first online inter-hospital endoscopic radiologic conference. The following are our objectives for this case. To discuss a case of an adult male presenting with fever and dyspeptic symptoms, to discuss the diagnostic approach and treatment of this disease, to highlight the use of endoscopic ultrasound-guided fine needle aspiration biopsy in the diagnosis of pancreatic lesions. Our patient is JR, a 56-year-old Filipino male, came in with a chief complaint of epigastric pain and fever. 3 weeks prior to consult, he presented with back pain, accompanied by fever and chills occurring any time of the day. He initially sought consult at a different institution. On the background of the patient's history of nephrolithiasis, he was assessed with a recurrent nephrolithiasis and underwent a CT sonogram. There was no nephrolithiasis noted, but it then revealed an enlarged and inhomogeneous pancreatic head with ill-defined borders and adjacent lymphadenopathies. A whole abdominal CT scan was then done and showed macrocystic multiseptated cystic foci in the pancreatic head that partially encased but did not invade the portal vein. There were also multiple para-aortic lymphadenopathies noted. Further workups, including chest X-ray and serum CA19-9, were all normal. Patient was advised endoscopic ultrasound but opted transfer to our institution. The patient then developed intermittent febrile episodes and eventually experienced epigastric pain, non-radiating, accompanied with early satiety and postprandial fullness. He also had poor appetite and unquantified weight loss. 2 weeks prior to consult, he sought consult with AMD for second opinion and was advised to undergo MRCP. So before proceeding to the MRCP of our patient, let us first look into the MRI planes. In MRI, the patient is seen from the feet upward. The abdomen can be viewed in the sagittal, coronal, and the transverse direction. In the T1 weighted sequence, the fat is bright and the fluid or water is hypointense. While in T1 fat suppressed, this is done for the purpose of IV contrast. The fat will be hypointense and this facilitates the detection of proteinaceous material, blood products, or contrast enhancement. In T2, the fat is bright, though not as bright as T1, and the fluid is also bright, unlike in T1 where it is hypointense. For the blood vessels, it is black or has flow void signals. Normally, the pancreas is hypointense. Pathologies detected in T2 weighted image are mostly bright. Cystic and necrotic components are also usually bright. Solid masses or soft tissues are intermediate to hypointense. Furthermore, in gadolinium study, it makes the lesion brighter. Take note of the diffusion restriction. In a diffusion-weighted image, or DWI, it is hyperintense with signal drop or corresponding hypointensity in ADC or the apparent diffusion coefficient, which is done in a pre-contrast study. Again, just to emphasize, in T1, fat is bright, water is hypointense. In T2, normally water and fat is bright. Otherwise, we'll show a pathology. And if there is diffusion restriction, it is characteristic of abscess or infection or cell-rich tissue. So let's move on to the MRCP of our patient. So here are the MRCP of our patient. This is in coronal view. This is the pancreatic head. The pancreas is normally hypointense in T2. And as we move on to deeper slices, we can see the hyperintense lesion on T2, which is shown as a lobulated hyperintense lesion measuring 3.2 by 3.6 centimeter arising in the head and uncinate process of the pancreas. The lesion shows peripheral enhancement after contrast administration. It appears bright on DWI and dark on ADC images, reflective of restricted diffusion. Here we can see the images of a normal body and tail of the pancreas. The pancreatic duct is not appreciated, indicating a non-dilated pancreatic duct. In this coronal view, it showed a multiple enlarged periportal and retroperitoneal lymph nodes showing peripheral enhancement and central areas of necrosis on post-contrast image. Here is an enlarged retroperitoneal lymph nodes. There is also hepatomegaly. Hepatic cysts are seen shown as hyperintensity in T2 with hypointense in portal venous phase or post-contrast. The common bile duct is top normal in size. Our patient had his follow-up done and was advised to undergo endoscopic ultrasound. The review of systems were unremarkable. For the patient's medical history, he is hypertensive, previously underwent ESWL, no history or exposure to pulmonary TB. He has no vices and denies illicit drug use. He has unremarkable sexual history, no recent travel. He has no family history of any GI diseases or malignancy. He has no jaundice, no cervical lymphadenopathies. Abdominal PE only revealed epigastric tenderness. Here are the salient features of the case. Our patient is a 56-year-old male, hypertensive, non-diabetic, presented with epigastric pain, early satiety, and postprandial fullness. He also had intermittent febrile episodes, has poor appetite, and unquantified weight loss. He has no history of TB disease or exposure. He has no vices and denies illicit drug use. He has no family history of malignancy. Our patient has normal vital signs and is afebrile on presentation. Sclera is anicteric with pink palpebral conjunctiva. There is no cervical lymphadenopathies. Abdomen is flabby with normoactive bowel sound. There is epigastric tenderness. There are no masses palpated. The liver and spleen are not palpable. CT scan showed macrocystic, multiseptated cluster of cysts in the pancreatic head, while MRCP revealed hyperintense lesion measuring 3.2 by 3.6 cm at the head and uncinate process of the pancreas. Periportal and retroperitoneal lymph nodes are also seen. Given the history and PE of our patient and the imaging findings, our initial impression is pancreatic head mass considering cystic neoplasm, with the following differential diagnosis. Pancreatic abscess, although it is rare and occurs as a complication of a severe acute pancreatitis, which our patient did not have, it can be less likely. However, due to rim-enhancing lesion as seen on MRI and presence of fever, we cannot totally rule this out. Another differential diagnosis is non-neoplastic cysts such as pseudocyst or its complication, mucinous non-neoplastic cyst, and lymphoepithelial cysts. On the same day of admission, endoscopic ultrasound was done. For the benefit of our new batch of second years and our first years, let us orient ourselves on the endoscopic ultrasound first. There are two types of EUS scopes, radial scanning and linear array. The radial type scans in a plane perpendicular to the axis of the scope to produce 360-degree image, similar to a CT slice. The transducer appears as a bull's eye within the image. The linear array type scans in a plane parallel to the axis of the scope. It is therapeutic in nature. It has the advantage of allowing visualization of a needle while performing a procedure. Depending on which station EUS is performed, whether the stomach, duodenal bulb, and the descending part of the duodenum, we could visualize particular regions, such as when we do EUS at the descending part of the duodenum or D2, we can appreciate the pancreatic head and uncinate process with these following landmarks. So to orient ourselves, the scope is passed into the second part of the duodenum and then taking a short turn. Clockwise rotation shows the uncinate process. So here. And then a little withdrawn of the scope. And another clockwise rotation shows the ampullary area. So in our case, initial endoscopic exam showed normal esophagus and stomach. Going further, there is a sinus tract at the D2 area just after passing the D1-D2 junction with purulent materials coming out of the sinus tract. So here we can see the fistulous tract, the sinus tract with a purulent material coming out from it. Endoscopic ultrasound showed an irregularly shaped, multicystic lesion with multiple septation and what appears as debris within the cyst located at the uncinate process of the pancreas. The lesion measures 5.6 cm in the widest diameter. So here, this is the cystic lesion. And then fine needle aspiration biopsy was carried out from the large cystic lesion, obtaining bloody specimen with purulent materials. So as we can see here, this is where the EUS needle did the biopsy. Okay. And then the sinus tract, seen endoscopically, appears to be continuous with the uncinate lesion, which was not seen during the MRCP of the patient. So here, this is the sinus tract or the fistulous tract. There are also several lymph nodes seen measuring about 2 cm at the celiac and perihepatic area with consistency similar to the cystic lesion at the uncinate process of the pancreas. So here we can appreciate the celiac lymph node. And then right here, we can appreciate the perihepatic lymph node. And this is the liver. So these are the still photos of the EUS. This is the duodenal fistula opening seen endoscopically. This is the pancreatic cystic mass lesion in the uncinate process where FNAB was carried out. These are the celiac and the perihepatic lymph nodes. And this is the fistulous tract that seems connected to the lesion in the uncinate process. This was signed out as pancreatic cystic mass lesion, uncinate process with perihepatic and celiac lymph nodes, status post FNAB, sinus tract and/or fistulous communication in the descending duodenum. He was then started on IV antibiotic after EUS. He was started with ertapenem until biopsy of the pancreas result revealed a chronic granulomatous inflammation with suppuration. In this smear, it shows small and large cluster of epithelioid histiocytes and admixed with polymorphous population of lymphocytes. The background showed many neutrophils and necrotic debris. Due to a high index of suspicion for TB, our patient was started with anti-COX regimen, a quadruple therapy of isoniazid, rifampicin, pyrazinamide, and ethambutol, which provided lysis of fever. However, there was inadequate sample for further TB testing. Hence, an EGD was done to recollect specimen samples. On EGD, the duodenal fistula revealed less pus. Further biopsies at the edges and within the fistula were collected and sent for MTB PCR and AFB stain. Both tests showed positive result. So here's the tuberculous bacilli stained by acid-fast bacilli. Stained by AFB stain. He became a febrile after the third day of initiating anti-COX or HRZE. He was sent home with improvement of symptoms. On his follow-up after 3 months, there was weight gain, resolution of fever, and abdominal pain. Completion of anti-COX regimen for 6 months was advised. Our final diagnosis for this case is isolated pancreatic tuberculosis with pancreatico-duodenal fistula. Pancreatic TB. Yes po,
Sorry.
doctor.
Kim, I think before you proceed with the discussion, I would like to ask our reactors if they have any questions or if they have any comments. Dr. Maralit, maybe would like to start.
Ayan, okay. Thank you, Kim, for that very interesting case. No? Actually, we've seen a couple of cases similar to yours. Meron ba kayo na-determine na risk factors during your investigation? Kasi you mentioned he has no history of pancreatic pulmonary TB, but does he have any history of, parang workup for HIV?
HIV was not workup at this time po, doctor. So we started with the anti-COX regimen and the patient actually improved. One of the consideration was to do this test, if there is no improvement on follow-up. However, the patient improved, so this was not done anymore. And other risk factor actually, doc, is just the place, Philippines, actually Filipino, and he lived here. And his work is actually a parang selling clothes at a retail store. Otherwise, he has no recent travel, no signs of, no unremarkable sexual history, no illicit drug use, or any forms that could predispose the patient of becoming immunocompromised.
So, Kim, I would respectfully disagree. No? The pancreas is relatively hypovascular compared to the rest of the GI tract. So, mas nakakakita kami ng hepatobiliary TB, ng GI TB, compared to pancreatic TB. So, even though your patient does not admit to any predisposition, one of our best suggestions would always be an ICC screen. I have encountered one pancreatic TB who turned out to be negative with ICC screening. However, he turned out positive for pulmonary. So mas common pa rin kasi parang when you hear of hooves, think of horses first before zebras. So that's one of the things I would like to reiterate to our
Hindi ko
fellows and
kumabalik
colleagues.
to nga news kaya kung picturean.
Actually, I agree with Ruther. Can you hear me?
Yes, sir.
Yes, we can hear you.
Yeah. Actually, for patients who have tuberculosis, especially in the pancreas, it's mandatory that you really have to have an HIV testing because pancreas is supposed to be very, very rarely involved even in extrapulmonary tuberculosis. Of course, extrapulmonary tuberculosis is the sixth among the ranks, but as far as the involvement of the pancreas, it's relatively not so involved in extrapulmonary tuberculosis. One, because of the pancreatic enzyme. You very well know, I think the fellows are well aware that you have lipase, the enzymes, the pancreatic enzymes, and that will actually prevent the tuberculosis from really growing in the pancreatic parenchyma. Second, you have your, we call it the DNAs, deoxyribonucleases, in the pancreatic enzyme as well, that will actually prevent or probably lower down the possibility of pancreatic tuberculosis. Although we've seen a few cases of pancreatic tuberculosis in PGH. When I was a fellow, we did a study on the pancreatic tuberculosis among patients who had actually among autopsy cases. Because during our time, it's a 90% autopsy in PGH. And we have found out that it only occurs in one a year. So that was a 10-year study. And we have found out that it only occurs one per year. In some studies, actually, if you have to review pancreatic tuberculosis, especially in India, it only occurs in about 2%. And you very well know that India has one of the highest tuberculosis in the world, similar to us probably. But despite that, pancreatic tuberculosis is really very unusual. So much so that they really require an HIV testing, even if patient, let's say, denies, extra, let's say, marital or what have you, activities. That's always one of the consideration. Now, I think it's also good that we have a radiologist. Maybe we can also ask Dr. Saulog if she can add something to what was described in the MRCP, because I think the macrocystic lesions that we've seen in the pancreas can also be seen in mucinous cyst adenoma, because the mucinous cyst adenoma is also macrocystic, and it can actually mimic your pancreatic tuberculosis. Can we ask our radiologist, Dr. Saulo?
Yes, go ahead.
Yeah.
Hi, good evening. The salient
Yes,
says,
Dr.
can you hear me?
Yes, Dr.
The salient feature of this study was the prominent necrotic lymph nodes in the peripancreatic and porta hepatis. That was
Can we visualize again the MRCP for the sake of the fellows, so that at least they will be able to. Okay, that's it. Yes, Doctora.
I think it's best to see it in the, do you have the actual Gadolino? Post-Gadolino.
I only have this two.
Okay, the one on the right upper. That's it. Okay. Okay. So that's the salient feature of this imaging. And when we see necrotic lymph nodes, TB is usually one of the first things that would come to our mind. Although this is not pathognomonic, but this is one of the most common causes of necrotic lymph nodes. There are other causes for necrotic lymph nodes like Kaposi sarcoma, which is prevalent in HIV patients, diffuse B-cell lymphoma, and cavitating lymph node syndrome in celiac disease, but not very common. Okay, if this case was just purely the lesion in the pancreatic head and no lymph nodes, then the other differential diagnoses like pseudocyst and mucinous adenoma, and maybe even a neuroendocrine tumor, which can also present as a cystic mass with peripheral enhancement. But the appearance of the necrotic lymph nodes plus the lesion in the pancreatic head would make me favor a granulomatous infection such as TB. The lesion in the pancreatic head is very similar to the lymph nodes that surrounds it. It's very similar.
Yes, Dr. Ruther, you want to say something? Go ahead, Dr. Ruther.
Because one of the more salient features in the patient's presentation is actually fever. So most cystic neoplasms in the pancreas are, do not present with fever unless they have secondary infection. So that's another clue. And for a middle-aged man with so many, parang lymphocytic spread or lymph node spread ang nangyari sa kanya kasi panay lymph nodes yung meron sa kanya. So I would really consider HIV in this patient.
Kim, at this time, I just have some questions from the audience. First is that, was a biopsy done in the fistulous tract?
Yes, they did, ma'am.
Yes,
They did, okay. And then another question is, well, I suppose any of the reactors can answer this. Do you think the TB of the lymph node extended to the pancreas and the duodenum, and it's not really an organic pancreatic TB?
Actually, okay, Ruther, you can go ahead.
I think, sir, it's better that you go ahead, sir. Sorry.
Actually, the most common is still hematogenous spread. Although, of course, there are several pathways in which TB can affect the pancreas. And one of them is really the lymph node involvement first, and then that lymph node will affect the pancreas. So in this case, you really have a lot of lymph nodes, peripancreatic lymph nodes, that could have been affected initially, and that could have affected the pancreas rather than a solitary pancreatic mass, because solitary pancreatic tuberculosis is really the exception rather than the rule. You have more of it's more of the miliary. The most common is miliary. And of course, the second will be involvement of the lymph nodes, and then involvement of the pancreas, and then later on the solitary pancreatic mass. And we've seen only very, very rarely solitary pancreatic mass. I think in my entire career, I've seen only 2 cases of solitary pancreatic mass. Most of the cases that we've seen are either involvement of the lymph nodes involved, and then later on involving the pancreas, or part and parcel of the miliary spread.
I actually agree with.
Thank you, Dr. Banya.
Yes.
Yeah, go ahead, Luther.
Ma'am Jet, I actually agree with Dr. Banyas na probably this started with the lymph nodes and then spread to the pancreas. As you can also see in the EUS, there was a big lymph node in the celiac axis or the celiac plexus area. The celiac lymph node is also quite huge. So I would suspect that this has been one of the primary lesions initially that has spread into the pancreas.
Kim, there's a request from one of the audience to review the EUS image, and maybe I could have Luther comment on this. Do you think the cysts were all similar in appearance under the EUS, Luther?
Actually, ma'am, if you can see, it's quite heterogeneous. because of the necrotic material inside the cyst. No, so usually cysts
Okay.
they usually are anechoic, no, inside. So and they have distinct walls. In this case, you can see some hyperechoic areas compared to hypoechoic areas. So there is some heterogeneity inside the cyst. So that is a clue for us, possibly that this is necrotic material. But you cannot say until you really get a biopsy.
Okay. Well taken. Point well taken, Ruther. So at this point, may we ask Kim to proceed with her case?
Judith, can I just ask?
Yes, Doc. Go ahead.
Regarding the MRCP and the CT, I think there was encasement of the vessel, but there was no invasion of the vessel. So was that also visualized in the EUS?
Hindi sir
Yes.
pinakita doon sa images sir na pinakita sa atin. Hindi sir pinakita yung portal vein eh. So probably sir baka pag nakita natin yung buong video pwedeng mapakita sa amin. But usually we can see that during EUS sir.
Because that is also one clue that you may be really dealing with
TB
inflammatory process, especially tuberculosis. Because if you are dealing with a malignancy, usually if there's vessel encasement, there's really actually encroachment
Yes.
of the vessel, not that much encasement. Okay, so I think for the red pit with the fellows, you have to always take a look whether there's really invasion already of the vessels.
Thank you Dr.
Actually-
Banyo. Excellent point po. Excellent point.
Can I say something? I agree that
go ahead.
when you have vascular involvement there, it would favor a neoplasm. But in some cases also, TB can also do that. Not common, but TB can still do that. And that makes it harder to differentiate it from neoplasm.
That's right, because there were case reports actually, not really large or so many cases, but only case reports that sometimes, of course, TBs, we really have to have a great respect for tuberculosis. It can really mimic neoplasm or adenocarcinoma, and it can even involve the vessel. But usually, it's just the engagement, but no invasion of the vessel.
Go ahead, Kim.
Actually, Doc, during the endoscopic ultrasound, there was no invasion of the portal vein, although we just failed to get a good picture of this. So to proceed with our discussion, pancreatic tuberculosis is first described by Auerbach. It is rare, is only found in case reports and small case studies. There is only one similar case reported by Sanchez et al. On pancreatic TB with duodenal fistula in a sub-Saharan African living in Spain. The most common route of spread of tuberculosis to the solid organs of the abdomen is the hematogenous route, and less commonly the lymphatic route, as mentioned earlier. Presumed pathophysiology of pancreatic involvement by TB includes direct extension from adjacent organs or lymph nodes, lymphatic or hematogenous dissemination, or after activation from a previous abdominal tuberculosis. In abdominal tuberculosis, ileocecal region is most commonly affected. Solid organs like the kidney, spleen, and liver get involved with tuberculosis much more commonly than the pancreas. Patient of pancreatic tuberculosis may remain asymptomatic initially and manifest as an abscess or a mass involving local lymph nodes and resembling carcinoma. The presenting symptoms of pancreatic TB include abdominal pain, abdominal mass, malaise, anorexia, weight loss, night sweats, backache, jaundice, and fever. In a study by Nagar et al. On 32 patients, it reported that the most common symptom was abdominal pain localized at the epigastric region. Sia et al. Also reported that the most common symptom is abdominal pain and that a nodule is present in 75% of cases, followed by malaise and weakness. Fever was the most common symptom in a case series of 13 patients. It is difficult to diagnose tuberculosis of pancreas on imaging studies as they may present with masses, cystic lesions or abscesses, and mass lesions in most of the cases mimicking pancreatic carcinoma. Pancreatic tuberculosis most commonly present as a solitary lesion with multiple cystic components. It is typically located in the pancreatic body or head. Peripancreatic lymphadenopathy can also be present. Woodfield et al. Concluded that radiologic appearances may be similar to a mucinous cystic neoplasm or could show a pancreatic mass with involvement of the pancreatic lymph nodes or a mass centered in a peripancreatic lymph node. Chattery et al. Concluded that endoscopic ultrasound is the diagnostic modality of choice for pancreatic tuberculosis and that linear EUS allows high-resolution imaging that can readily differentiate pancreatic and peripancreatic masses. Furthermore, EUS is more effective than CT or ultrasound in distinguishing between malignant and non-malignant lesions of the pancreas. It is also superior to CT or ultrasound in sampling particularly small lesions of the pancreas. Because of the rarity of pancreatic TB, however, the diagnostic accuracy of EUS-guided fine needle aspiration cytology for this condition is difficult to determine, where EUS FNA cytology was reported to be 76 to 95% for pancreatic cancer and 46% for focal inflammation. FNA not only confirms tuberculous etiology but also rules out malignancy. In addition to EUS FNA cytology, biopsy cytology in pancreatic TB will show granulomatous inflammation, epithelioid histiocytes, plasma cells, and lymphocytes, while acid-fast bacilli are rarely seen. Treatment is with anti-COX regimen with duration varying from 6 to 12 months, depending on severity. However, the DOTS recommends only 6 months of therapy for abdominal TB, even in severe forms. In conclusion, isolated pancreatic TB is a rare clinical entity but should always be in the list of differential diagnoses in a patient with pancreatic mass, especially in the developing world where the infection is endemic. Pancreatic tuberculosis closely mimics pancreatic carcinoma in clinical presentation and radiologic appearances. High index of suspicion is warranted to diagnose the condition early to prevent unnecessary surgical intervention and associated morbidity. In the appropriate clinical setting, EUS appearance of solid or mixed solid cystic lesions in the pancreas with hypoechoic and anechoic echo texture and no vascular invasion should suggest the possibility of tuberculosis. EUS FNA cytology is a safe and effective method for diagnosing pancreatic TB. Once again, from St. Luke's Medical Center's Quezon City, thank you po.
All right, thank you, Kim. But before we move on to the next case, we'd just like to ask a few more questions. Ruther, I see you raising your hand.
Yes,
I
ma'am.
see you raising your
Ma'am,
hand. Go ahead,
sorry.
Ruther.
So, Ma'am Jet, one thing I need to clarify lang po kasi nabanggit ni Kim, baka hindi lang na-emphasize no, na even though patient is nag-i-improve with anti-TB treatment, that doesn't mean that the patient cannot have coexistence with HIV. Yun lang po. So, even if the patient improves, you should check for HIV status.
All right. Yes, Ruther, I think I took note of that. I think everyone is in agreement that there should still be a testing for HIV. And my question maybe for Ruther and for Dr. Banyas, do you think there's still a need to do a repeat EUS and biopsy after the anti-TB treatment for this patient? Would you like to do a repeat? Because you mentioned that we should also take note of the possibility that there might be some underlying malignancies. Peter?
Ma'am, from our standpoint po, since maganda po yung area na na-access ng biopsy, I don't need to do a repeat EUS. Probably a repeat imaging of the pancreas, but not necessarily an EUS po kasi it's invasive and quite expensive po.
Okay.
So after treatment po, I'll probably repeat a pancreas protocol CT scan or an MRI with pancreas po para makita ko lang kung nag-improve na talaga yung area.
Yes.
I agree with Ruther. Actually, I think since US is a little bit expensive, and if it's just for follow-up, especially this time of pandemic, I think that will really cost a lot if you have to wear, let's say, your PPEs just to do your follow-up. So I think an imaging can be done in this case after, let's say, 6 months of treatment, since most of these patients will respond to a 6-month HRC The other thing that I
I
would
have
like
a question,
to ask is uh,
doctor.
how come, let's say, if you have a big mass in the pancreas, um, why is it that very rarely do we have, let's say, pancreatic ductal dilatation in cases of pancreatic TB? Although, of course, if you have a fistula, that can probably drain the pancreatic duct and probably decrease the incidence of pancreatic ductal dilatation. But in a lot of literature, rarely do they see pancreatic ductal dilatation in cases of pancreatic TB. Maybe our presenter would like to venture, or maybe some of the consultants can venture an explanation.
Anyone?
Although I was thinking that maybe the pancreatic enzyme per se is the one that is really preventing the invasion of the pancreatic duct. So
Yes,
much
Doc.
only have the pancreatic parenchyma that is involved.
Yes, Doc. There are actually multiple studies indicating that that could have been the explanation of why pancreatic TB is rare because of the pancreatic enzymes. Also, to add, doctor, very recently, a CT scan was repeated to this patient, and it actually showed resolution of the pancreatic mass and lymph nodes already.
We have a question from Dr. RG de Guzman to our radiologist, Dr. Anna. Dr. RG is asking, can encasement of the portal vein lead to stenosis of the portal vein in your experience? Dr. Anna?
Yes, encasement can lead to narrowing of the portal vein.
Yeah, the question is, can encasement of the portal vein lead to stenosis of the portal vein in your experience?
Yes, it can. But actually, for this particular case, there was no actual invasion based on the MRI. There was no real invasion. Maybe there was just like mass effect to the portal vein, but no real invasion.
All right. RG, I think your question with regards to the treatment has already been answered. And I think I'll... Okay. Dr. Frederick D mentioned or answered the question of Dr. RG de Guzman that stenosis is possible if there's portal vein invasion. But in this case, there wasn't any portal vein invasion. Is that correct?
Yes, none po.
All right. Last question to maybe our reactors from Dr. Manly Uy. If there is still cystic lesion on post-treatment imaging, would you want to do an FNA? Could this be a mucinous, could it be an MCN with superimposed TB? Any comment, Ruther? Dr. Banya?
I'll consider that if the patient is HIV negative. But if the patient is HIV negative, that I would consider that TB was secondary to a malignancy. But however, if the patient is immunocompetent, I'd probably not consider repeating an EUS unless the size of the cystic lesions increased after treatment.
All right.
Or maybe if the patient is still symptomatic, but since the follow-up say, according to Dr. Anna, the patient has improved already markedly, even the size of the cyst has improved. But was an HIV really done in this patient? I mean,
it was not done po, doctor, but it was considered if the patient did not improve with the medications.
Although, of course, the fellow should always consider this.
Yes, doc.
But before you treat the patient for TB, especially if you are, let's say, dealing with an extrapulmonary tuberculosis, it's really mandatory that you have to check for HIV because you may have a flare of the TB once you start your, let's say, antiviral for the HIV, or if you don't really check for the HIV and the patient is really HIV positive, you may really have, let's say, a flare also of the HIV, even if you are giving your anti-TB drugs.
All right, thank you very much, Kim. Let's proceed to our next case. Our second case will be delivered by a fellow of the UERMMMC. We have Dr. Arvin Lawrence Salvador. Dr. Salvador, you can go ahead and share your slides with us.
Thank you, doctors.
Thank you, Kim.
po.
Arvin, go ahead.
Just a second. Okay, is it working? So for today, I'm Arvin Salvador, and I will be representing UERM for today's ERC. So for the patient profile, we have a 55-year-old male, Filipino and Roman Catholic, who came in with the chief complaint of dysphagia of 4 months duration. 4 months prior to consult, the patient had complained of dysphagia to solid foods. He had no difficulty swallowing the food, but would feel that the food would get stuck at the level of his chest a few minutes after swallowing. This would usually occur when he ate chunks of meat and fruit, which would be relieved after intake of water and adequate mastication. The patient was able to tolerate moist bread, porridge, and liquids, and the patient did not have any episodes of vomiting or coughing. He had no episodes of drooling, nor were there episodes of adynophagia or chest pain. And symptoms did not progress until a week prior to consult. The patient complained of episodes of melena. The stool was soft, non-foul smelling, and would occur once or twice a day. There were no episodes of hematemesis, hematochezia, or abdominal pains. When the patient developed weakness, that's the time he consulted and prompted the current admission. For the past medical history of the patient had poor reliability. We tried to retrieve previous hospital records, but those efforts were in vain. The patient only knew some of the diagnoses that he had prior to admission. So the patient was diagnosed with liver cirrhosis secondary to probable schistosomiasis back in 2000, and then he underwent an unknown esophageal surgery and devascularization with splenectomy for refractory variceal bleeding. Subsequently, the patient did not have any other consult with other institutions or any other doctor until the present admission. For the social history of the patient is a non-smoker, non-alcoholic beverage drinker with no history of drug use. Upon admission at the UERM, the patient was weak-looking, he had stable vital signs, and the only remarkable physical exam for the head and neck was the pale papule conjunctiva. The chest and lungs had no remarkable examination. For the abdominal PE, the patient had an abdomen that was globular, non-distended. It had a surgical scar located transversely along the right and left subcostal area, no caput medusae. There was no fluid wave. The patient had normal active bowel sounds. It was soft on palpation with no tenderness. The liver span was 7 centimeters at the midclavicular line. It had a smooth, palpable edge with no masses. On rectal exam, there were no external hemorrhoids. The sphincter tone was tight, and the examining finger had black stools. So for the salient features of the case, we have a 55-year-old male who underwent an unknown esophageal surgery for recurrent variceal bleeding, diagnosed with cirrhosis, no episodic and progressive dysphagia to solid food. He had no adynophagia, with non-significant weight loss, no complaints of abdominal pain or symptoms of reflux, with no recent intake of medications. Initially, the patient was diagnosed with dysphagia secondary to a probable post-operative stricture, then through out malignancy. And then the upper GI bleed was secondary to a variceal bleeding or a bleeding peptic ulcer, then through out malignancy. Subsequently, the patient then underwent water-soluble esophagogram. Here, there is persistent narrowing at the proximal esophagus at the level of the C6 and C7 vertebral bodies. There's resultant fusiform dilation proximal to the narrowing at the level of the C4 and C5 vertebral bodies. The following are still images of the esophagogram. As you can see, there is good passage of contrast to the distal segments, and there's observed pooling of contrast at the proximal end of the strictured area. The narrowed contrast filled proximal esophagus measured approximately 1.1 centimeters in length and 0.4 centimeters in diameter. There was resultant segmental dilation of the more proximal segment of the esophagus. So subsequently, the patient underwent upper GI endoscopy. So there was a circumferential narrowing noted at 18 centimeters from the incisors. Further advancement of the scope was unsuccessful due to resistance. The area around the stenotic area had normal-looking mucosa with no areas of granuloma. So from that, the service decided to dilate the stenotic area. A guide wire was inserted through the stenotic area with fluoroscopic guidance. The tip of the guide wire was identified at the antrum. A subregular dilator was then passed over the guide wire until the level of the stricture. The stricture was dilated using 7, 9, and 11 millimeters of the subregular dilators. Then, as you can note, there's a noted increase in the size of the lumen with a minimal tear with minimal bleeding noted. However, further advancement of the scope was still unsuccessful. Thinking that there is upper GI bleeding and to explore this possibility, the service decided to use a controlled radial expansion dilator, and it was inflated with diameters of 12 millimeters and 13.5 millimeters, and each diameter was held in place for 2 minutes. After which, the gastroscope was able to pass through the stenotic area. From here, it can be noted that there was a significant increase in the size of the lumen with minimal bleeding. From that point on, there was noted that the esophagus had normal-looking mucosa, and we can note here at around 30 centimeters from the incisors, there was supposedly the CEJ. The endoscopic proper revealed that there were no obvious lesions at the gastric mucosa. There was no evidence of portal hypertensive gastropathy, and then the pyloric ring was round and distensible. The duodenum had normal-looking mucosa. So here is the stenotic area. I mean the anastomotic site. Okay, so post-operatively, the patient underwent a chest X-ray, which revealed no evidence of pneumothorax. He was placed on NPO, and subsequently, his diet was progressed. Throughout the admission, the patient did not encounter any episodes of dysphagia. For the anemia, the patient was primed for colonoscopy and further workup. However, due to financial constraints, all of the plans were set on hold. So the patient was advised for possibility of the recurrence of a stricture and advised for possible repeat dilation and the use of adjunctive methods. We also primed the patient for workup for the anemia as well as the probable cause of the stenotic area. However, due to the desire of the patient to be discharged, we weren't able to do the following tests. So for the final impression of the patient, so we have dysphagia, secondary to a benign esophageal stricture, probably an esophageal web, to consider Plummer-Vinson syndrome, and then the anemia, secondary to probable lower GI bleed, and then to rule out an iron deficiency anemia.
Arvin, before you proceed, would the reactors care to comment at this point? Or do you have any questions to Arvin, Drs. Bañez, Dr. Moralit, and Dr. Saulog?
Yes, actually, if the patient underwent devascularization at 2000 and you see an anastomotic area at the distal esophagus, what could have been done would be a Segura's technique, because that would entail, let's say, esophageal transection, devascularization, splenectomy,
Yes, sir.
vagotomy, and pyloroplasty. So the only thing that I would like to ask is, how come there? I mean, of course, Plummer-Vinson syndrome can produce the web, but if you are entertaining this, patient should have been anemic way back rather than just now.
Yes, sir.
And you have Melina to explain the anemia of this patient. So maybe there's something else aside from the Plummer-Vinson. Now, the other thing that I would like to comment is, if you would like to dilate, and I don't know if Ruther would agree with me, if you would like to dilate a stricture, and your scope, let's say in this case, I think it was an H180,
Yes, sir.
according to
Yes,
the
sir. Yes, sir.
yes, and H180 has a 9.8 millimeter diameter, almost 10 millimeter. Usually, before you can insert your scope after dilatation, you have to dilate 2 steps up. That means about 4 millimeter. So if you have used your 7, 9, 11, you will not be able really to insert your scope because your scope is 10 millimeter. You have to dilate it to about 14. Of course, for the sake of the fellows, if you are using Savary-Gillard, it's only 7, 9, 11, 12. There's no 13, probably because they fear, they have the phobia for the number 13. So you don't have a 13 for Savary-Gillard. You only have 11, and then later 12, 14. And if you will be inserting your 10 millimeter or 9.8 millimeter scope, you have to probably dilate it to about 14 so that you will be able to insert your scope, which you actually did that using your CRE. But if you have your 14 millimeter, let's say Savary-Gillard, you could just make use of that instead of adding expenses for this patient.
Ruther?
Ma'am Jet, I definitely agree with Dr. Bañez regarding the Savary-Gillard. However, in my experience po, in Singapore, when we're dealing with proximal strictures, instead of using the Savary-Gillard, we would usually do the CRE because of a relatively controlled dilatation. Circumferential po kasi yung pag-dilate nun. Unlike sa Savary-Gillard, usually you shear one side, and as you increase it, sometimes kasi it becomes bloody. So when it becomes bloody and it's very close to the upper esophageal sphincter, patient has a high tendency to aspirate blood. So and then the patient develops chemical pneumonitis. So what we try to do, if it's proximal, we try to do it na CRE po. But if you are forced because you don't have any CRE, then I agree with Dr. Bañez. Definitely, you need to use 2 Savary-Gillards bigger than what you used to dilate, so that there will be no. Kasi there is also high recurrence rate for these strictures, which you guys mentioned already. And I agree with Dr. Bañez also that before you consider Plummer-Vinson, probably work out the patient kasi nga medyo matanda na yung patient and then suddenly nag-present na. Ngayon lang siya nag-present ng anemia. By the way,
Right.
question.
I was gonna ask, Ruther, I was gonna ask if there was an additional value of using the Savary-Gillard dilators first instead of just proceeding straight away with the use of the CRE. Is there any advantage to that? Because I was thinking if this were my case, I would probably just go ahead with the CRE. But is there a distinct advantage of doing dilatation with the Savary Gillard first and then proceeding with the CRE?
Dr. Banyo, sir.
Actually, in this case, since your scope is 9.8 millimeter, and if you don't have really, let's say, a 14 millimeter Savary Gillard, you can go straight to a CRE using maybe your 13 or 15 millimeter diameter, so that at least you will not be using two instruments in this case. Plus the fact that, of course, I agree with Ruther that if you are dealing with a proximal stricture and you are using Savary Gillard, which is a shearing force rather than a radial force by your CRE, then you may have more bleeding and you may have aspiration during the procedure. But in this case, I think if you really would like to prevent aspiration during your dilatation, maybe you can ask your anesthesiologist to do
Right.
general anesthesia.
General anesthesia, sir. Yes, sir.
Yeah. So there's a question. Can Plummer-Vinson syndrome web look like this? Shouldn't it be membranous? Anyone can answer?
Usually, Plummer-Vinson is really membranous, not really this scar-like lesion. Because take note that if you visualize the endoscopy report, it looks like a scarred area. So I was really asking, how come the patient has a proximal stricture? Well, in fact, if you have, let's say, a Siguras technique done to 2000, you are expecting maybe a distal esophageal stricture, because in those cases, you have to transect the esophagus and then reanastomose. But in this case, you have a proximal stricture. So there must be something there. Of course, I think that should be worked up also. And maybe you can go back to your patient and ask, is there anything else, let's say, that transpired between 2000 and 2020? That it's a 20
No,
year
sir. No,
period.
sir. We were trying to retrieve records from the previous hospital, but we weren't able to get any records from that place. And then we asked the patient if he had any records from home. No, sir. We're trying to determine what was the cause of the stenotic area during that time as well. And then what were the other surgeries that he went through, so that, but efforts were in vain, sir.
Okay.
All right, Arvin, you can. Arvin, go ahead and
Yes.
proceed.
Okay, thank you po. So in the evaluation of patients with dysphagia, we first have to determine if the dysphagia is coming from oropharyngeal or esophageal in origin. Basing on history alone, this can be done. So a patient who complains of difficulty initiating a swallow or repeatedly has attempts to swallow may have problems that affects the mouth, the hypopharynx, and the upper esophagus. And this will be exhibited as frequent coughing episodes, drooling, or sometimes frequent salivation. And clearly, the patient did not have any of those symptoms. Then, you have to consider that the cause of dysphagia is esophageal in origin. So for these patients, we ask 3 questions. So what type of food or liquid causes the symptoms? Is the dysphagia intermittent or progressive? Or does the patient have any episodes of heartburn? From that, we can distinguish the etiology of the dysphagia of the patient. So patients who present with dysphagia immediately to both solid and liquid would more likely have an esophageal motility disorder, or sometimes they would also have episodes of chest pain aggravated by intake of hot or cold liquids. And clearly, the patient also did not encounter any of those symptoms. Hence, a more structural cause of the origin of dysphagia should be considered. So in evaluation of patients with dysphagia, we can use the following modalities. The use of contrast esophagogram can be able to establish the location of the stricture, its length, the number of strictures located, the diameter as well as the associated pathology like a diverticula that would complicate the case. You can use either a barium or water-soluble contrast for the procedure. The upper GI endoscopy can provide direct visualization of the suspected lesion as well as to perform and need for therapy. So for esophageal strictures, they are characterized as a narrowing of the esophageal lumen, and its pathophysiology involves inflammation, fibrosis, or neoplasia that can cause damage to the underlying mucosa. And the cause of the stricture is dependent on the underlying etiology of the disease. Strictures are separated into benign or malignant lesions, and that symptoms develop once the esophageal lumen is less than 13 millimeters in diameter. So the following are some of the causes of strictures, esophageal strictures. Benign strictures are classified as follows, and while malignant strictures are considered as malignancies. So for the kind of stricture, they can be classified into simple or complex. Simple strictures are soft, smooth surface with straight or located in the distal esophagus, while complex strictures have a longer length, which is more than 2 centimeters long. They are tortuous and narrow, and sometimes they are associated with other disease pathologies. So prior to 1989, benign esophageal strictures were most commonly caused by peptic strictures. However, due to the advent of proton pump inhibitors, iatrogenic strictures became the most common cause. So in the management of these patients, the first line of treatment is still to do a dilation therapy, and its goal is to provide symptomatic relief of dysphagia due to anatomic or the functional narrowing of the esophagus. So when performing the dilation technique, we have to take into consideration the following side adverse effects. So the most common of which is perforation, which occurs in 0.1 to 2.6% of patients with undergoing dilatory procedures. Bleeding is also a common adverse effect, while aspiration is also common. The following tools can be used to dilate the esophageal strictures. So we have Wade type dilators, which can be used as and they rely on tactile perception to determine the amount of resistance encountered with passages through the esophagus. They come in a variety of graduating sizes, and then the Wade type dilators, like the Maloney dilators, can be used for simple strictures, while wire-guided dilators, like the Savary-Guillard, have a tapered and rigid tip with a central hollow core for the patches of the guide wire. They are marked with a radiopaque band, and then at the level of their maximal diameter for fluoroscopy. So for balloon dilators, they are either single diameter or multiple size diameters, and then they can either be passed over a guide wire or through the scope. So here's the basic setup for patients undergoing wire-guided boogie dilation. The guide wire is passed through the esophagus so that its tip is positioned in the antrum. The process can be done under fluoroscopic guidance or under direct endoscopic visualization. The dilator is passed over the guide wire with a small, smooth movement until the maximal dilator is beyond the stricture. During this time, retraction of the wire may be done, and then during the endoscopic process, the primary endoscopist could feel a give at the strictured area. For all the processes for mechanical dilators, the rule of 3 is usually taken into consideration. This tenet is based on the principle that strictures take time to develop, and that it's inappropriate and unnecessary to put a patient at increased risk of perforation by trying to dilate too much or too quickly. So the rule states that no more than 3 dilators of progressively increasing diameter should be passed after moderate resistance is encountered. However, these tenets are not evidence-based, and in fact, one retrospective study have determined that as gender, morphology, location, and dilator type are not really associated with perforation if they don't adhere to the rule of 3. So balloon dilators, on the other hand, can be positioned at the proximal end of the stricture, and then the dilator is advanced through the accessory channel over the guide wire through the stricture. Then they can be inflated at a for 30 to 60 seconds or until there's a notable drop in the manometric pressure within the dilator. So in determining which dilator or technique to use, there is no significant difference in the efficacy of boogie versus balloon dilators. And the meta-analysis composed of 5 randomized controlled trials totaling 461 patients, endoscopic dilation using boogie versus balloon dilation were compared by measured outcomes related to symptomatic relief and recurrence rate. So the meta-analysis also compared adverse events. So the results revealed that in this forest plot, there seemed to be no difference between the use of boogie dilation versus balloon dilation in the management of benign esophageal strictures. Ultimately, the decision on which dilation technique to be used will depend on the underlying etiology and the level of complexity of the stricture. So in selecting the appropriate technique, it will depend on the underlying etiology and the level of expertise of the endoscopist. It will also depend on what kind of tool wherein the endoscopist is most comfortable with. We can do aggressive dilations depending on the need of the case, like to explore possible causes of bleeding. And determining the cause of the stricture effectively will also lead to the better management of the patient. So the target diameter and the safe level of dilation remains to be unknown, but there have been studies that target or patients who underwent dilation of about 16 to 20 millimeters have ensured longer dilation-free period and longer recurrence of esophageal strictures. So this study done by Halsema et al. Was done to determine the ideal dilation of esophageal strictures. In this study, patients underwent endoscopic dilation up to 16 millimeters, and they were compared to patients who underwent dilation of up to more than 16 millimeters. So they found out that in patients who underwent a maximum diameter of 16 millimeters had a recurrence rate of 79.5% with a dilation-free period of 41.5 days. Meanwhile, in the group that was dilated more than 16 millimeters, the recurrence rate was 68.1% with a dilation-free period of 92 days. So endoscopic dilation over 16 millimeters resulted in a significant prolongation of dilation-free period in comparison to those patients dilated under 16 millimeters. So the effectivity of boogie and balloon dilation may reach to a needed success rate of 90%. However, 30 to 40% of these patients may develop recurrence of dysphagia, which occurs within the first year of follow-up. So in these patients, we define refractory strictures as experience of dysphagia despite dilation of over 14 millimeters over 5 sessions at 2-week intervals. And then they are recurrent if the patency of the stenotic area is changed within 4 weeks after the target diameter is reached. So these strict recurrence of strictures are affected by the following processes. So if the etiology is caustic, peptic, or there are complex strictures like strictures caused by anastomotic strictures, they are more common to have recurrence or refractory strictures. With that in mind, early benign stricture development should be and diameter of stricture during the first endoscopy were predictive factors for repeat Bougainage therapy. And by identifying these patients, they can undergo a more aggressive or use of alternative techniques in order to dilate the stricture very well. So the following are adjunctive measures that we can use for refractory cases of esophageal strictures. So as a wrap-up, esophageal strictures may be classified according to morphology, etiology, or even as benign or malignant. And their presenting symptoms are usually dysphagia or weight loss. In determining whether or not, or whether which to use, boogie or balloon dilation, there is no significant difference in between the two methods chosen, and that dilating the stricture to up to 16 millimeters may result in significant prolongation of dilation-free period and time to stricture recurrence. So the occurrence of recurrent strictures are affected by the underlying etiology, and by determining these underlying etiology efficiently, we can already use advanced methods for treating the strictures immediately, or we can anticipate the use of advanced methods to relieve the symptoms and the stricture at once. Thank you. That ends my presentation.
Thank you, Arvin. Very quickly to our reactors, would you have biopsied the proximal stricture? Ruther, Dr. Banyas, would you have biopsied the proximal stricture?
I think that is the thing that should have been done. Of course, this is in retrospect, and because when you do it retrospectively, it's a 20/20 vision. So, but since you really don't have an etiology on why the patient, or a clear view on why the patient had proximal stricture, I think that is mandated that to do, let's say, the other problem probably that this patient would have, this would really, let's say, a scarred tissue to begin with, is the stenosis. So I don't know what happened to the patient post dilatation.
And I think we still have some unanswered questions, right? I mean, we don't really know the source of the melena, and we don't really know the etiology of the anemia of this patient because of lack of further workups, like Arvin.
Yes, ma'am.
Right.
We tried to prime the patient regarding the possible workup for all the etiologies involved, but since the patient did not have any other, he had financial constraints, we were limited by the present funds of the patient to completely get the diagnosis of the patient. And then during this time, we were already in lockdown, so the funds were really limited, and we tried to our very best to determine the etiology, but sadly.
Right. So maybe it would be nice if maybe you could give us some follow-up information with regards to this patient. So we have a few more minutes left. So any last words, Dr. Maralit?
Wala naman, ma'am. There was a comment by Dr. RG, ma'am, no, regarding during, if you're going to use CRE, will you do more than 15 millimeters? Ako, ma'am, during first dilation siguro, I will not go beyond 15 millimeters. If I'm going to use CRE. But yung sequential po, I go up probably up to about 18 millimeters. Depends on how frequent the restenosis occurs po. So, Arvin, I have just one question. How often do you do you do stage dilatation pa after the first dilatation, or are you happy with the size na ginawa ninyo? Kasi in my limited experience, they really do re-stenose. So meron nga kami after dilatation, after 8 days stenotic na uli eh. So parang inuulit-ulit lang namin na inuulit. We tried triamcinolone. So, do you have encountered any studies na...
Actually, sir, we primed the patient for repeated dilation since these patients do have high recurrence rate of stricture formation. And then we also primed the patient for possible use of adjunctive methods like incisional therapy, usage of steroids, or fibrinolytic agents. But yun nga, sir, we were limited by the funds of the patient, but we really planned them for serial dilation with repeated sessions to ensure that the patency of the stricture would be more than 16 millimeters. As I've mentioned with the discussion part, they've attained better symptom-free period with using dilation that's more than 16 millimeters. And then at this diameter, we shouldn't be scared of encountering aspiration perforation, since at this diameter, they have proven that going more than 3 diameters bigger would not result to significant perforation episodes. If the cause is...
Dr. B, sir, what's your experience, sir? How do you manage these kinds of patients, sir?
So are you asking me, Ruther?
Yes, sir. Yes, sir.
So actually, what I've taught you and all the other fellows, Manila doctors and PGH,
yes, sir.
If you are using your Sabary Gillard, if you see blood already, you can do another step up.
Yes, sir. Just
Good
one more
to
surgery.
step up, but one more step up will be safe. So
Yes, sir.
once you've seen blood in your subregular dilator, then you can actually do one more step. So if you see blood in a 12 millimeter subregular, you can step up to 14 millimeter.
Yes,
Usually
sir.
we don't encounter perforation.
Yes,
Now,
sir.
but of course, if you really would like to be brave, you can actually do another step up to 15 or 16. But usually I do it that way.
Yes,
When
sir.
I see blood, I just do another step up.
Actually, sir, I would still follow you. I will not be brave enough to do it more than once, sir.
Yeah, and you can actually repeat the dilatation maybe 2 to 3 weeks time.
Yes, sir. 2 to
And
3 weeks.
see whether, I mean, if you can really dilate the stenosis some more, so that at least the patient will not have much of the dysphagia.
All right, thank you very much. So I'd like to thank our excellent the excellent presentations of our fellows Kim and Arvin, and for giving us such interesting cases this evening, and also the brilliant insights of our reactors. At this stage, I would like to thank our sponsor who provided the much needed boost to the PSDE Zoom account that allowed us to accommodate more participants for this first ERC. And that's none other than our friends from High SI. At this juncture, I would like to call Mr. Mardy Dizon, the Senior Product Manager, to say a few words to us. Mardy?
Yes, Doctora. Good evening, everyone. Good evening, doctors. So again, allow me to introduce myself. I'm Mardy, the Senior Product Manager of HiSI handling GI brands like Pariet and Gasmutin. And together with me is Mr. Mike Dimaano, our IT and SFE Manager. So HiSI Doctor is a human healthcare company, and we give first thought to patients and the family and their families to increasing the benefits healthcare provides. And again, in behalf of HiSI, we would like to thank the Philippine Society of Digestive Endoscopy for giving us this great opportunity to be your partner again for this year in our endoscopic radiologic conference. And it's actually a great honor to be part of this venue of learnings, and of course to be of service to you doctors. So again, congratulations also to our presenter, to Dr. Rakim and Dr. Arvin. Congratulations. And once again po, maraming salamat for this great opportunity. Thank you, Dr.
Thank you very much, Mr. Dizon. And to close this conference, we have Dr. Benjamin Perez, the current Vice President of the Philippine Society of Digestive Endoscopy. Benj?
Hi, thank you, Jet. Good evening to all the participants, and thank you to the fellows for your great presentation. I'd like to again thank also HiSI for this support that you've been giving ERC. So this is a new thing for the ERC of PSDE. We used last year, the other year, we started having transmissions from the different hospitals so that the fellows could avoid the traffic. And this year, because of the COVID, we are forced to have this webinar as a webinar instead of the usual live ERCs that we are used to. Hopefully this will be temporary, but for now, this is the way we will be doing it. And it seems like a good way for our other members to participate and to watch this ERC and gain knowledge. The last count was about 138 were the active participants. So that we have a very good number of members of the PSD who were attending besides the fellows. So thank you to everyone for attending this ERC. I'd like to remind you to answer the survey that we have after this, so that we can improve the ERC and as a method of grading the fellows, no? And also I'd like to remind you that the next ERC will be on July 9, be hosted by UPPGH and Manila Doctors. So I'll see you then on July 9. Have a good evening, and thank you for attending this conference.
Thank you very much, Benj. I would just like to ask the indulgence of everyone. Very quickly, may I call on Eric Yasay? I think he would like to just give a short announcement. Eric?
Hi, ma'am. Thank you for the opportunity. So I'd just like to invite all the first years and those who are interested to join the EBM workshop tomorrow. We will begin at 8 a.m. So we have sent you the Zoom link. So just click on the Zoom link and the password. Remember to log in with your confirmed Zoom account. So see you all tomorrow at 8 a.m. Okay, so it's required for first years. And to those who are interested, yung second years, you can repeat the course and you can even invite your consultants. Thank you very much.
Thanks, Eric. All right, so with that, on behalf of the Philippine Society of Digestive Endoscopy, HI-SI, and our two hosts for this evening, St. Luke's Medical Center, Quezon City, and UERM, I'd like to express our gratitude for sharing your time with us. And we hope to invite you again, as mentioned by Benji, for the next ERC slated on July 19 to be hosted by UPPGH and Manila Doctors Hospital. Have a good night, everyone. Stay safe and God bless. Bye.
Bye. Bye.
Bye.
Thank you, Jet, for being moderator.
Yeah,
You're
thank you, Dr.
welcome.
Jet.
My pleasure.
Thank you, Ma'am
Bye.
Jet.
Thank
Be
you.
safe,
Good night.
everyone. Maraming salamat
Bye-bye.
po.
Bye.
Sige na, sir. Play mo yung ano.